There we go. Yeah, you can take control, right?
Yeah.
Yeah, thank you.
All right. Okay, good. For those people who are now joining the recording, sorry you missed the best 10 minutes of the talk. It's all downhill from here. Anyway, so yeah, I actually started skiing by my first trip was in the Monmouth County Medical Explorers ski trip. I don't know if they still do that or not, but it was a group called Medical Explorers. It was a subset of Boy Scouts of America. It came out of Monmouth County, and every year they had an annual ski trip, and that was the first one first time I really went skiing, and that's how I got into that. I've recently started golfing. It's been about a year and a half. I've been trying to learn how to golf. You'll see a little bit later on. It's kind of one of the things I like to do is try to learn new things. And you know, one of the greatest joys of my life has been spending time getting to know my son. So, you know, growing up, I was always curious about how the body works, how things work in general. Not, you know, how machines work, how computers work. I spent a lot of time learning how to program, and I always want to try to learn new things, and I was always very inquisitive about that. And so, you know, naturally, I was very much interested in medicine and learning about medicine, learning how to take care of people, learning anatomy. My favorite time in high school was when we would have, you know, mammalian anatomy labs. I really enjoyed that as part of my science classes, you know, and I knew growing up, I don't really know why, I just always had a feeling and a sensation that I wanted to be a heart surgeon. So after high school, or in high school, I got into a few colleges, and I also got into a couple of BSMD programs. I decided to choose the BSMD program at Albany Medical College with Union College. At that time, that was 3 years of undergraduate education and then 4 years of medical school. Since then, I think that's changed, and now it's an 8-year BSMD program, and you get actually a BS, and then you get a Master's of Health Administration, and then you get an MD. I was a part of the requirement of the program at that time was to have a non-science major. So you had to double major. You could major in a science and a non-science. And so I chose as my second major economics. So I was biology and economics. And I really liked that. It forced me to have some depth of understanding and some depth in what I do. I took a lot of non-science type classes. I wanted to learn about, you know, math. I really enjoyed taking math classes. It had nothing to do with medicine. I knew I'd be doing medicine for the rest of my life. So I wanted to explore other things and really provide some depth to my understanding. I also became an EMT while in college, and we started with a couple of other guys the campus EMT program that ran actually for quite some time. Only recently has it shut down and become a professional EMT program that's rolled into campus security. And then I went to med school. I continued doing some EMT work on the side in med school. I knew I wanted to be a heart surgeon. So initially, as soon as I got started in med school, I went and spoke to the heart surgeons, and I said, hey, I want to be a heart surgeon. I want to see what's going on. I spent a lot of time in medical school with the heart surgeons, learning how to do, you know, different things, learning about how heart surgery is done, seeing how their life is. You know, I would fly out with them to get organs for transplant. I would stay for the transplant. I would, you know, I spend a lot of time being awake and trying to push things forward with regards to really living a life of a heart surgeon to try to better understand if this is really what I wanted to do. And after medical school, I got into residency at Duke University in Durham, North Carolina, and I did my residency in general surgery there. Subsequently, I did 3 years of cardiothoracic training, and in my last year, I focused on heart and lung transplant. And then once I was finished with my training, I was on faculty at Duke for 10 years before I was recruited to Emory to to run the section of thoracic transplantation. The section of thoracic transplantation at Emory has 5 other faculty members in it. There are 3 who do heart transplant in addition to me. And then it's right now I'm the only faculty member doing lung transplant, but we're actively recruiting for other faculty members so that I don't have to be the only one. So, I think there's a lot, there's a lot of struggles to try to go into medicine. I think everybody feels it. There's a lot of people who want to do it. There's a lot of competition. There's a lot of stress. There's a lot to learn because there's a huge body of knowledge you have to be able to be successful in medicine. That being said, you have a lot of time to learn it. I mean, when I look back, I spent almost, almost 20 years, 17, 18 years to become a heart surgeon, So it's a lot of time to learn what you need to learn. Also, if you think about it, well, it's a huge investment of time. And we'll touch upon that a little bit later. It's part of, as you're trying to make the decision as to whether or not you want to do this. I think extracurriculars are really important, especially in high school. Part of your job in high school and college, especially if you want to go into medicine, is to learn how it is you learn best. Because after college, you think high school is hard. You get into college is different. Then medical school, you're learning essentially every month, you're learning whatever you learned in 4 years in high school every month in medical school, so you have to get very efficient and good at learning. And so your job, if you want to be a good medical student, is to learn how you best learn so that you can then have those skills to be able to digest and assimilate and learn everything you need to learn in medical school. In case you don't know, medical schools in general, now there's some that are different, but for the most part, in the United States, they do 2 years of clinical work. And that clinical work can be done in various ways. They've started these new age things of case-based learning and problem-solving based learning and all that stuff. But ultimately, it boils down to you're spending, excuse me 1 second, I'm sorry. I'm on call, so I have to answer this call.
If any of you ever have any questions, you can always put them in the chat. I'll be looking at it throughout. And if there is anything pertaining to Dr. Daneshmand himself, I'll let him know.
Sorry about that. So, I think really understanding how you learn and being able to capture that skill is important. And it's something that you want to spend some time. It takes a while. There's a lot of trial and error. There's a lot of, you may learn different ways for different things. So I think that's an important skill. Really spend some time. I really enjoyed my science classes in high school and in college, and having a strong science foundation is really important for medical school. It makes some of these things, some of the more esoteric concepts of medicine easier. Physics and math are actually very helpful. Some of the logic classes that come with advanced math, I think really turned out to be actually very helpful for me in medical school. But don't forget that medicine is a human interaction specialty. And, the most successful doctors, surgeons, internists, doesn't matter. The most successful doctors are those who can make a connection with their patients. And you have to have some breadth, some depth to you, some understanding of different things to be able to make connections with a wide variety of people who may come from many different walks of life, who may have many different backgrounds. And you have to be able to establish that therapeutic relationship. And so having a broad-based liberal arts type understanding and learning is helpful. Spending time in your English classes, as much as I personally hated it at the time in high school and college, reading, Shakespeare and Chaucer and all this other stuff, I wanted to, bang my head against the wall. But it actually provided me tools to now better interact with my patients. I took sociology courses, I took psychology courses. All of these really allowed me to have better relationships with my patients. And then I had interests in things outside of medicine that, again, could potentially help foster that relationship and allow you to connect with your patients. Let's keep going here. So as you're trying to choose, medicine, no matter what you do in medicine, okay, it's hard. There's a huge time commitment, right? We just talked about how I invested 17 years of my life. 17 years, just think about that. 17 years of my life were invested to becoming a heart surgeon. In that time, I had, as soon as I graduated from high school, even before that, but as soon as I graduated from high school, I no longer had summers off. I no longer, on my summers off, I was doing research, working in a research lab and doing all these different things with the one express goal of becoming a heart surgeon. So, and I was in a rush to do that. And when I look back, maybe I didn't, need to spend as much time, but it, ultimately I did achieve my goal. And so you got to ask yourself, is that something you want to invest? There's a concept in economics called opportunity cost. What were all the other things that I could have done in that time that maybe provided me more, could have provided me more enjoyment, or could have provided me more income than becoming in medicine? There's never enough money that you can be paid in medicine. You will never be paid enough money, no matter what you do, to compensate for what you give up. You make a huge financial investment from the get-go. College, medical school are very expensive. Then you make a huge time investment, and you give up a lot of important things. I was a resident, and as a resident, you don't get paid that much money at all. When I was a resident, my intern year, I made $29,000 a year, and I was working over 110, 112 hours, sometimes 120 hours a week. So when you calculate that out, it was probably making less than minimum wage. Okay. I was a resident working like crazy. My college roommate, my best friend, got married. I couldn't be at his wedding. That's a huge opportunity cost. That's, I gave up that experience and that time for my training in medicine. Now, things have gotten better. There's, work hour restrictions, and there's time off guarantees that have to happen now. And those are all very good. But it's still, you're restricted to 80 hours a week. You have to have one day off a week. It's not a usual 9-to-5 job. And let me tell you, at least in heart surgery, once you finish, you're working 190 hours a week. It's, it's maybe one night a week that I get to put my son to bed. And, that's probably my most favorite thing in the world to do, is to come home, have dinner with my son. We play a little bit. We go upstairs. He gets a bath. We read a few books together, and I put him to bed. And guess what? I only get to do that once a week. Otherwise, I'm here in the hospital operating, doing other things. So you got to understand that, you have to really be obsessed. And there has to be nothing else you want to do. Because if you're thinking about, oh, I want to do this for the money, you're going to wind up, or the prestige or whatever you may think. If it's not, I want to do this because I don't want to do anything else. I want to be a heart surgeon who is taking care of these critically ill patients. Well, you're not going to be happy. You're not going to be effective, and you're not going to be able to get your, the appropriate balance that you need in your life. I think it's interesting, that heart surgery is talked a lot about on TV, and, TV shows like Grey's Anatomy and like The Good Doctor and all that stuff portray these things of, like, surgeons coming around and doing all these different things and doing all these different procedures that, you don't do, and oftentimes both in TV and in real life, people don't understand the difference between a cardiologist and a cardiothoracic surgeon. So cardiologists train in internal medicine, and then they train in the medical management of heart disease. After they complete that, some, they'll be ready to be physicians. Some of them decide to take extra training and they become interventional cardiologists. So after internal medicine and then cardiology, they do interventional cardiology training. And then those are the people who put stents in coronary arteries when people have heart attacks or something like that. Some of those interventional cardiologists will then go do additional training to become structural interventional cardiologists. So those are the people who do the transcatheter valves together with surgeons. Those are valves that are put in through the groin or through the neck to replace the aortic valve or the mitral valve. And they partner with surgeons to do that. Surgeons, on the other hand, cardiothoracic surgeons, are trained in one of three ways, really one of two ways. One way is dedicated cardiothoracic surgery training, which happens recently. Sorry, another phone call. Pardon me.
All right. I see someone has a question in the chat, but I will, let him know, of course, when he's on this call.
This is your life. You can't do anything without getting a bunch of phone calls all the time, about, and each one of them is related to patient care, and you can't not answer them. You're, no matter where you are, you got to answer those phone calls.
We actually,
Go ahead.
We have a question in the chat from Karina,
Sure.
Which is, in terms of the human aspect of medicine, what advice would you give to individuals interested in medicine to help them hone their bedside manner so that they don't come across as too clinical or detached?
I think I think you guys have a slide about that. So if it's okay, we'll table that until we get to that slide. So anyway, so surgeons, the way you become a cardiothoracic surgeon is go to medical school, and then there's a new pathway. It's been around for about 5 or so years, where you can get into cardiothoracic training straight out of medical school. And it's 6 years. It's called the integrated 6-year pathway. Most of those people are unable to really learn everything they need to learn in 6 years. And so oftentimes they'll do additional training time, 1 or 2 years after those 6 years. So it comes out to be about 8 years after finishing medical school, where you can be a completely independent heart surgeon. Alternatively, and this is the way I did it, and this is the way, it was the only way when I was finishing medical school that was an option. You could train, you would do general surgery training for 5 years. And after 5 years of general surgery, you would do 3 years of cardiothoracic surgery. As part and parcel to most residency programs now, they'll have 2 years of research in there, which I had too. So, you know, even those I6 programs, the integrated programs, really wind up being 9 or 10 years long with the research and the additional fellowships you do on the back end. Essentially it's a 10-year commitment, and it's very similar to cardiology. So if you want to become a regular cardiologist, you do 3 years of internal medicine and 3 years of cardiology. That's 6 years. Now, if you want to become an interventional cardiologist, you have to do at least another 1 year after that doing interventional cardiology. If you want to become a structural cardiologist, you do 1 year after that. So that's 8 years of training to become a structural cardiologist. Similarly, if you want to become an electrophysiologist, for example, you would do internal medicine, cardiology, and then 3 years of electrophysiology training. So it's a huge time commitment for these specialties. And it's not like on TV where you just kind of go ahead and do you know, any surgery or whatever, and you know the second year resident is doing a heart transplant or something like that. No, it takes a lot of time to learn that. So what's my typical day? I get up, you know, between 5:30 and 6. Today I got up at 5. On Monday, on Tuesday I got up at 4 because we had meetings and other things that I had to deal with. I have, unfortunately, a lot of administrative meetings that I have to deal with, and those I schedule them in the morning for before my clinical day starts. Then I get on a Zoom. I sometimes nowadays, because it's a little bit easier on Zoom, before I used to have to leave the house around 5:30 or 6 to get into these meetings. Now I can start my Zoom meetings as I'm going into work. Once I'm done with my morning meetings, I see my patient before surgery, make sure they don't have any last minute questions. And I, you know, while they're preparing my patient to undergo surgery, I look at the computer, look at all the labs, look at the x-rays, get caught up on what happened in the last, 4 or 5 hours while I'd been asleep. I go and round on all my patients. I see, at any point I may have 8 or 10 patients in the ICU and another 8 or 10 patients on the floor. I see all of them. We talk about the plans for the day. We talk to their families. As part of that rounds, there'll be residents and other trainees there who we teach along the way. And then we go to the OR and get started with surgery. We're in a teaching institution, so I'm teaching residents how to do surgery, and depending on their level, they'll be doing various aspects of the procedure, potentially all of the procedure with me assisting them. For the most part, my practice is complex patients who have been turned down at other centers. That's kind of the life of a more senior academic surgeon is going to be a lot of times things like that, cases that were turned down by other people. Just because you're scrubbed doesn't mean you don't get the phone calls. I have my AirPods that they're in, and I have these little things called ear hawks. I don't know if you guys can see them. I attach to my AirPods. They go in my ear and they don't come out. And Siri is my best friend. It was a recent feature they added to Siri on the AirPods Pro, where when the phone rings, you can tell it to answer without having to touch it. Otherwise, I'd always had to have a nurse say yes on my phone to answer the phone, and getting phone calls about my patients all the time. In general, that's what my days. I spend my days Monday, Thursday, Friday in the operating room. Usually I try not to operate on Tuesdays and Wednesdays, although I operated today, and I operated yesterday. So Tuesdays in general are my non-operative days, where I try to do as many administrative meetings as I can and other programmatic meetings that are necessary for my responsibilities in the programs. And Wednesdays I see patients in in the office and then have administrative and research meetings in the afternoon. I go home somewhere between 7 and 9 p.m. on the nights that I do go home. Last week, I did 2 heart transplants and 2 lung transplants in addition to 8 regular surgeries. So I only went home, I think, 1 or 2 nights last week. So it was a busy week. This week has been less busy. I'm hoping to go home tonight. I got home last night around 9 o'clock. Yeah. And that is about, that's kind of my typical work week. I think heart surgery is a technically demanding field. Every person in the world has got a tremor. You have to learn to kind of control that tremor and be able to do microsurgery. The surgeries are long. We're operating sometimes on vessels. We're putting vessels together that have a diameter of 1 or 2 millimeters, sewing them together with suture that is got that's less thick than hair, and needles that are very, very small. We use these magnifying glasses we call loops. I think I have a pair here I can show you. These are loops, and you put them on, and they got these optics on them, and they magnify things for you. You wear them over your eyes. You got a headlight on. I think one of the biggest things you don't realize, especially during your training, is that you're always working. I technically was off for New Year's, but I spent every day checking up on my patients, talking to the residents, talking to my partners about, they were rounding on my patients. I didn't schedule any surgeries, but there's care that needs to be happening at all times. Even after your training, it takes time, right? So I've probably, for the first 3 or 4 years that I was an attending surgeon, I didn't have as good judgment or knowledge as I do now. And you're always constantly learning, and we're human beings make mistakes. The job is to learn from your mistakes and not make them in the future. And as you get older and more experienced, you make less mistakes. You make mistakes less frequently because you've already made them once before and you learn from them. But it takes a long time to really become an expert in this job. So let's talk about some cases, and then we'll finish up with some advice, which I think will address the question we had in the chat. So this was a young lady, 24 years old. She developed viral myocarditis. So she had a flu-like infection, got better, and then started having heart failure symptoms, shortness of breath. She is a dental hygienist. She was at work and she arrested. Her heart stopped and they started CPR on her. They took her to an outside hospital. This case happened when I was at Duke. They placed her on a portable heart-lung machine called ECMO at the outside hospital. The ECMO stabilized her circulation, and she was transferred over to Duke. At that point, we took her to the operating room and converted her to essentially 2 pumps that were functioning as an artificial heart. One was taking blood from her body and sending it to her lungs, and one was taking blood from her lungs and sending it to her body. Luckily, her brain recovered, her kidneys recovered, and we supported her on that for weeks. Over the course of weeks, her heart function improved and got stronger, which happens in about half the cases of viral myocarditis. And she was able to, we were able to get the pumps out, and she went home and got married. And, she sent me a Christmas card this holiday season. Her and her husband have been married for just over a year now. She sends me updates all the time. It's fantastic. And she would be dead if it weren't for these technologies and for heart surgeons. And there's lots of these cases, and this really is something that provides you a lot of satisfaction, but it can also provide you a lot of stress and angst. You can imagine what it's like talking to the mother and father of a young 20-something woman, and saying to them, we have your daughter on life support. That's the maximum amount of life support we can provide to any human being. We don't know if she's going to live or die. And, you know, it's a difficult conversation to have with anybody, let alone the parents of a young woman. On the other side of the spectrum, this is kind of, this is an interesting operation. And this is something that a program that I've developed here at Emory. We have there's a very small incidence in the world of tumors of the heart. And so because of that, there's only a few centers that do heart surgery for cancer and tumors in the heart. And we're one of them here at Emory, and it's a program that I started. And we do, it's called Cardio-Oncology. And there's three centers in North America: Emory, Houston, and then University of Toronto in Canada. So this young lady is an art teacher, high school art teacher. She started having progressive shortness of breath and noticing that her belly was getting bigger. She thought she's just getting older and she's getting fat, and she tried to exercise and diet, and it didn't get any better and didn't get any better. And shortness of breath was really bad. So she went to the hospital. She got a CAT scan, and it showed that she had a tumor starting in her uterus or her ovaries, going all the way into her heart. So she was transferred over here, and we assembled a team. There was a urology, a surgical oncologist, a gynecology oncologist, and I was the cardio oncologist. And so we took her to the operating room. We started by opening her abdomen, and we took out her uterus and her ovaries. The tumor was growing up through her vena cava into her heart. So we opened her chest, put her on the heart-lung machine, then opened her vena cava and her heart, and were able to remove the tumor. And we took tumor out of the right side of her heart, and it had actually grown up into her lungs, and we were able to take all of it out of her lungs, fixed everything, put everything back together. And, it turned out the tumor, although it was growing aggressively and would have killed her probably in the next, month, it turned out that tumor was benign. And we were able to cure her, and she was fine, and she was able to recover, and in the matter of a week, she went from thinking that she was going to be dead to being completely fine and never had a problem. And, she was very grateful. She gave me, she painted actually something for me. It was very nice. It's she's an art teacher, so she painted this for me, and I keep it in my office. But you get a lot of enjoyment from that. So I don't want to paint a picture of it's just horrible and hard and sad, and but there are other ways to get enjoyment from being a heart surgeon, especially doing kind of crazy things. But it takes a long time. It's a huge amount of delayed gratification. I invested many years before I was able to get to that point. So what's my advice to you guys? I think, spend as much, what you're doing today is great. It's really important. Spend as much time as you can understanding what the life is like. I can't tell you how many people show up and they have no concept of what kind of commitment it takes to be a safe and good heart surgeon. And unfortunately, those are the people who don't make it. And it's really bad. You don't want to be somebody who goes to college and goes to medical school and spends all that money and spends all that time, and then you just drop out of your residency training and have to do something else. I mean, you can do that. There's nothing wrong with doing that. It's better to do that than to do something you hate and suffer, because you're not going to be good at it, and you're not going to, you're not going to be able to really have fulfillment from it. But it's difficult. I think I gained a lot of experience being an EMT. I think that was very, very helpful. I think it helped me understand what it's like to care for people. It helped me understand what it's like to deliver news to people, to talk to them. And really, it's your only avenue to start doing true patient care. I think it's important that you experience direct patient care. And maybe I would wait for a post-COVID world if we ever reach that. But I would volunteer. I would become an EMT. I would, see if you even like, patients. And because, it's taking care of people is glamorous on TV. It's not in real life. It's stinky, it's smelly, it's tiring, it's, it's dirty. It's not what it looks like on TV. What really helped me, I think, better be able to relate to patients is practice. I spent a lot of time, volunteering at, back then it was called Riverview Medical Center in Red Bank, New Jersey, but I think it's now Meridian Health or something like that. It's in Red Bank, New Jersey. And, I spent hundreds of hours there. I think I wound up with like 600 or 700 hours total of volunteering hours there. And I think it's important, spend a lot of time as a volunteer talking to patients, understanding what it's like to be a patient, understanding their frustrations. You're probably the only person there who really has the time to relate to them. And I think that's important. Learning how to interact with patients through direct practice, I think is the best way. And then having depth, if you're somebody who only, sits there and studies science and doesn't study anything else, doesn't experience anything else, doesn't have any other interests, well, it's hard for you to relate with patients. It's hard for you to, connect with them on a human level. And believe it or not, even though we're all humans, it takes practice to connect with people on a human level. It takes practice to not talk down to people. It takes practice to not alienate them. It's very easy to walk in a patient's room and start throwing a bunch of jargon around and start, telling them things and try to, push forward on a lot of things. It's a lot harder to walk into a patient's room and sit down and listen and try to make a connection and understand where they're coming from. I think now we're in the Q&A session. Is that correct?
Yep, that's so if any of you have any questions for Dr. Daneshmand, you can ask them now about anything discussed in this. This can help you on your quiz to clarify anything, ask him for, a personal question. You can ask Shadow Bunny as an organization, but this time is for you to ask any questions. So yes, if you have any questions, go right ahead. Oh, I will allow everyone to unmute if you would like to do that. You can also type it in the chat. Might take some time to type. You mind if I take control back?
Oh, please, yeah. Can I, what do I?
I got it.
Perfect.
Yeah. So someone asked in the chat, what is one of the most interesting research cases you've partaken or taken part in?
Yeah. So, one of the things we're doing research-wise, which I think is super exciting, is in transplantation. So there are ways that we do transplantation right now. Donor organs are allocated after a donor is declared brain dead. So in the United States, there is a law called the Dead Donor Law, and it is illegal to procure organs from somebody who is not dead, with the few exceptions. Those exceptions being kidney transplant. If there's a single kidney, somebody wants to donate their kidney, they can. Partial liver transplant, because our livers actually regenerate, so you can donate part of your liver. Or a lobar lung transplant, so somebody could donate a piece of their lung to somebody else. Outside of that, any other transplant, full liver, both kidneys, lungs, heart, etc., because the transplant would result, the procuring of those organs for transplant would result in the death of the donor, you cannot take organs from that donor unless they're dead. Now, in the United States, there's two ways that people are defined as dead. You can be circulatory dead, which is what we all know. You don't have a pulse, you're not moving, etc. Or you can be brain dead. So you can have sustained such a significant brain injury that you meet the strict criteria for brain death. And, the criteria for brain death are deliberately strict so that we don't accidentally kill somebody, So up until now, it was very difficult to take hearts from donors who experienced circulatory death. You could only take hearts from brain dead donors. You can imagine you don't want to take a donor heart from somebody whose heart has stopped. But kidneys, liver, etc., they were doing from circulatory death donors. And so a new technology has been devised. That technology is devised by two heart surgeons who started a company called the Transmedics Company. And that company has designed a pump called the Organ Care System. And what we can do with this pump is we can take the heart out of the body and reperfuse it and reanimate it and test it and to see if it's sustained any injury or not. And if it hasn't sustained injury, then use it for transplant. And we were doing this as research up until recently. Now we're doing it as part of our routine work. So it is a very exciting and promising technology, and it has given us access to 30% more donors than we otherwise would not have access to.
Very interesting. All right, one more I have is you kind of answered this, but what can a high school student do to prepare themselves, either in general or just within a subject?
Yeah, I mean, I think your best bet, I highly recommend becoming an EMT, and spending some time really doing EMT work. I think you should volunteer in a hospital, in a patient care area, somewhere where you're actually on the floor in the ward, seeing patients, talking to them, talking to the nurses and the doctors who are going to be there, to gain a lot of experience. I know some doctors work in a clinic and maybe never go to the hospital, but all of them were trained in the hospital. So that's the best place to learn about how to take care of patients.
All right, and then the last one I have is what is the best way to contact a doctor or an institution for finding medical research opportunities as a student on the pre-med track?
Yeah, so I think it's for somebody in high school, it can be a little bit difficult. There is a lot of the research that needs to be done requires a little bit of knowledge and expertise. That being said, there are data collection and other avenues to help contribute to research opportunities. Your best bet is to, I think everybody here is in New Jersey, right?
We're not sure of the locations, but probably not all of us are in New Jersey. The organization is based in New Jersey, though.
Gotcha. Okay. Well, I think your best bet is to, if you're definitely interested in doing clinical, research, is to reach out to your closest medical school, look on their website, find people who are doing research and email them and say, hey, I want to come and volunteer and help. Just understand that it's going to be a numbers game. You're going to have to reach out to a lot of people because oftentimes they won't necessarily have either the time or the funding to take on a student at the high school level. Taking on where it may be better for research work is to really, start looking in when you go to college, some of that time, and also just kind of doing, learning the fundamentals of the scientific process and scientific principles by working in a lab in a college.
Yeah. All right. Thank you so much for answering all of our questions. That's pretty much it. I'd like to give Dr. Daneshmand and all of today's attendees on behalf of Shadow Bunny and our co-founders, as well as the rest of our team, huge thank you for being here. I will link the quiz in the chat right now. The quiz is not only available in the chat, you'll also find it in our Instagram. If you follow our Instagram, which is _Shadow Bunny, you can find it in our bio. I will copy and paste the quiz right now. Again, to get the hours for this session, you need to fill out this quiz and get a 70 or above. Those of you who joined late, this is available to be recorded. It will be posted on our YouTube. Our YouTube channel link is in the chat. So you can access it through that. You can also access our YouTube through Instagram. For further information on our webinars such as this one, but with various specialties, before this, in this month, we had a dermatologist and stuff like that. You can join our Discord and get to our website to sign up for our newsletter. Similar to our Discord, you'll find a lot of our information, Zoom links and stuff there. Thank you all for coming. Thank you again, Dr. Daneshmand. And those of you who get a 70% or above will get your certificates in your email soon. Thank you so much. Have a nice night.
Take care.
You too.